Thank you very much. Okay. So I'm really going to talk about an area that really doesn't receive as much attention as it should in the world of pediatric HIV. And this is essentially comorbidities in adolescents, perinatally infected adolescents who've been growing up with HIV acquired at birth. And the point I want to first make is that when we're talking about cognitive disease, there are a huge number of heterogeneities which will affect people's risk and progression with neurocognitive disease. So the first thing to say is that adolescents with HIV are not a heterogeneous bunch. And one heterogeneity is that some adolescents today will have acquired HIV at birth, perinatally, and will have started HIV treatment at birth. Then you've got a much larger majority that have actually been infected at birth, but have started HIV treatment in later childhood and adolescence. And then you've got a third group that is actually acquiring HIV behaviorally in the adolescence period. And this is going to become very important with respect to their risk of neurocognitive disease. And do remember, and you've heard this time and time again at this meeting, is that we haven't stopped perinatal infections yet. We're still seeing 150,000 perinatal infections a year, and ART coverage in children is lagging behind that of adults. So we've still got water entering into the pot of children with HIV starting ART in later childhood. Then the other aspect is that obviously the criteria for ART initiation and the regimens have changed over the years. So the current cohort of adolescents, some of them will have been treatment experienced and have used many different regimens. And clearly one other aspect that is going to affect people's risk of getting neurocognitive disease is their virological control. And this is not virological control at one time point, but across childhood. So we need to be thinking about this in a much more longitudinal manner than we have hitherto. The other aspect is when they start HIV treatment, i.e. how immunosuppressed and how much disease severity that they have. So you will all be familiar with the sort of progressive neonatal encephalopathy that was recognized in the pre-ART era in children who were fast progressors, and they got a global encephalopathy, and that continues to have residual neurocognitive defects. So you can see that it's a very, very heterogeneous milieu and landscape when we're thinking about risk factors for neurocognitive disease. And then another thing that adds complexity to it is that during the period of adolescence, while the brain volume is not growing bigger, there's neuromaturation occurring. So there'll be more cognitive development happening across the adolescence period, and that is influenced by the social and environmental milieu. And I want you to remember this when you think about all the studies and the research and the patients that you're going to see with potential neurocognitive disease, because it's a very heterogeneous condition in terms of its presentation, in terms of what it looks like, but also in terms of who is at risk. So this is a very, very nice study that I quote often. It comes from the CIPHER collaboration that did a global meta-analysis of adolescents and was published in 2018. And what you can really see is, if you look at the panel on your left, and the purple line is Africa, and the red line is United States. What you can see is that the median age of starting ART is about 8 years in Africa, and the median age of starting ART in the United States was less than 1. So that really, what we're seeing is that a large proportion of adolescents today living with HIV in Africa have not started ART in early childhood. Similarly, many African children will have started ART when their CD4 counts are much lower. And also what you can see on panel C on the far right is that they are stunted, which is a marker of immune suppression. So that really does influence individuals' risks of comorbidities as well as particularly neurocognitive disease. And this is one study that shows it really well. This is from the SHARE trial that many of you will be aware of. It was the first trial that looked at immediate ART rather than deferred ART in infants, and showed very, very conclusively that it reduced mortality in babies if they started art straight away. But what they also did was looked at neurodevelopment. And what they showed was that children who started art early, compared to those where they had deferred art, had better locomotor quotient scores. But overall, the scores were lower in individuals who were HIV infected. So what that implies is that there is a window of opportunity to have neuroprotection if you start art in infancy. And many of the adolescents alive today will have missed the opportunity. And that is also illustrated very clearly if you look at the PREDICT trial that was conducted in Southeast Asia. And what they did was also a trial of looking at early versus deferred art, and didn't show any impact on mortality, but the numbers were small. But what's really interesting is that if you look at those who started art early, which are the individuals in circle, compared to individuals who deferred art, there was no difference in either full-scale IQ, verbal IQ, performance IQ, or processing speed. What this would imply is that these were children where the trials were taking place once they had left infancy. So the impact of art, early art, was much less marked. But across these parameters, children without HIV, either children exposed but uninfected or unexposed children, had a much better sort of neurocognitive parameters than children who were infected with HIV. So similar studies do show that there is a difference between adolescents with HIV and adolescents without. So we know that very clearly. But what I want to talk to you a little bit about is to unpick some of the studies that we have today. And the first message is that it's a very complicated set of studies that we have, because the studies are extremely heterogeneous with respect to the adolescents they include. Many of the studies in high-income countries have recruited adolescents who started art much earlier than studies in Africa where adolescents have started art later. The study designs are, again, quite heterogeneous, and particularly in terms of selection of control group. So if you compare them with HIV-exposed individuals, where we know that there is also a risk of neurocognitive disease, versus if you compare them to HIV-unexposed infants, there is clearly respect to environmental factors which play a role in neurocognitive disease. So the HIV-exposed uninfected are much more similar to the HIV-infected individuals. So, it's a very complicated thing to unpick. So selection of control groups, appropriate control groups, is very important. Many of the studies don't actually have control groups, and that's problematic in adolescence, because how do you untease the heterogeneity when it's a period when you're undergoing a lot of neurocognitive maturation and where you have socioeconomic factors that do affect your risk? The other problem with studying neurocognitive disease is the testing instruments that are used for measuring cognitive function and behavior. And if you look at the literature, you will find that there are a myriad of instruments used, and some of them are not necessarily validated to the local context. And even if you look at neuroimaging methods, there is some heterogeneity there. And I'm bringing this up so that when you look at the literature around neurocognitive disease, that it helps you to kind of position and actually work your way through what neurocognitive disease is, because it is fairly heterogeneous. Okay, so I'm going to show you some of the brain imaging studies that have been used. So there are lots of different brain imaging methods that are now available, both structural imaging and functional imaging. So on the left, you see the structural MRI that many of you will be used to, that shows you white and gray matter abnormalities. And the picture there shows a scan of an adolescent with decreased white matter volume in the external capsule on the scan on the top, and in the pons and corpus callosum at the bottom. So that's a scan that we are very commonly used to seeing in clinical practice. But then you've got other imaging modalities. So there's diffuse tensor imaging, for instance, which looks at the diffusion of water molecules and the kind of diffusion gradient of water molecules, and can allow you to actually then ascertain white matter microstructure through images that are actually capturing that. And a very nice study from South Africa at the bottom, which shows how DTI imaging has been used to look at gyrification of brain matter. So, so you're really now starting to look at microstructure. And then you have functional types of MRI, magnetic resonance imaging. So you've got, for example, functional MRIs that are looking at blood oxygen level dependent contrast. So essentially areas of higher blood flow and areas of attenuated blood flow. So areas of higher blood flow will be those that are kind of high areas of activity, even at resting state. So people are beginning to look at those gradients when they look at MRIs, and doesn't require any activity. It's non-invasive, but it's beginning to give you areas that are functionally more active than just looking at micro or macro structure, as in the scans on the left. Then you've got MR spectroscopic imaging that basically can allow you to look at electromagnetic radiation, if you will, that comes from different metabolites in the brain. And this is one study that actually shows the 4 different types of metabolites, and again is showing you neural activity. So it's a much more functional type of imaging. So just to show you, this is not to make you experts into any of this, but they're not necessarily all comparable scans. But essentially, when you put and look at the literature together, what we do know is that the brain structure and function differ in adolescents with HIV who are on treatment compared to those who are uninfected. That we do know. So there is brain structural and functional change. And what we begin to see is that there is lower gray and white matter volume. There is reduced cortical surface area, and there is evidence of damage to neuronal microstructure, so the axons and the nerve fibers. And we also see altered neurometabolite levels. And many of the studies show association with cognitive function. Now, you can imagine why this is complicated. You're using different imaging modalities, and different imaging modalities often focus on different regions of the brain. Now, the brain is an extremely complex organ. Different areas of the brain do different things, and there's incredible heterogeneity in different bits of the brain doing different things, and then you're comparing them to very different cognitive parameters. So those are 2 issues to remember, but overall we do know that the brain has abnormalities in terms of structure and function. The other thing to remember is there's a lot of selection bias in terms of controls that I talked about, and heterogeneity in terms of age and art duration. And what we're lacking is longitudinal studies, which is incredibly important given that this is an intense period of neurodevelopmental change. So what we're seeing at the age of 10 may look very different by the time you image the same individual when they're aged 17 or 18 years, particularly when you look at their microstructure and their neurometabolite profile. Oops, sorry. Okay, so I've already told you that there is real clear evidence emerging from the studies that have been done across this continent that there is change to structure and structure and neurometabolites. But what does that actually mean in terms of what it's manifest clinically? Now, there are 6, the DSM, Diagnostic and Statistical Manual of Mental Disorders, characterizes neurocognitive function into 6 domains. So social cognition, which is how we process and use information to inform our social behavior. Language, how we communicate, read, write, and speak. Complex attention, how we are able to kind of sustain our attention, divide our attention, and give selective attention. Learning and memory, which is what people usually tend to think about, but it isn't just memory that makes up our function. Perceptual and motor function, how we use our senses to move in the environment, using our senses. And finally, executive function, which essentially is what controls and coordinates our other cognitive domains. And it's how we plan, organize, prioritize, decide, and move between tasks. So, in infants, we're very familiar with the global HIV-associated encephalopathy, but that's the very extreme end of the spectrum. What we're beginning to see in adolescents are 4 areas that are particularly affected. So one is executive functioning, which is individuals' ability to plan. What am I going to do? How am I going to take? And you can imagine how that might have, for example, a really big impact in how people plan their day-to-day activities, etc. How quick they are at processing, moving between selected attention and divided attention. So, people might appear slower because the processing speed, working memory, so what you're focusing on now rather than your long-term memory, and visuospatial ability. So studies vary, but consistently in systematic reviews, these are the 4 domains and areas that we see deficits in adolescents living with perinatally acquired HIV. Okay, so I just want to I'm not an immunopathogenic expert by any stretch of the imagination. I'm very much a clinical epidemiologist. But we have some idea of possible pathogenic mechanisms, but it's not been an easy area to study. But there are several mechanisms that are postulated. So as we know that HIV is a very neurotropic virus, and very, very early on in infection, the brain is infected by the virus, and which is why in children with perinatally acquired HIV, we see the brain affected so commonly. And there is some evidence that there is retention of the virus and continued neuroinflammation, which may result in progressive damage and neurocognitive decline. There's a big debate about what we call CSF HIV RNA escape, whereby the drugs that are put in the blood will lower viral load in the blood, but those drugs don't have complete coverage in ability to basically suppress viral multiplication in the brain. We also know that systemic inflammation occurs due to kind of dysregulated systemic immune activation, and several studies have shown an association between the dysregulated inflammation and activation and neurocognitive disease. And it's certainly a postulated mechanism for other comorbidities, particularly cardiovascular comorbidity in adults. So that's a postulated mechanism. The other thing which is less commonly recognized is vasculopathy. A recent study from Zambia found a high proportion of individuals had vasculitis and stenosis on vascular imaging in brains of children or older children and adolescents living with HIV. And one must not underestimate how much substance use and alcohol itself has impacts on brain structural alterations. So all these are mechanisms by which neurocognitive damage might occur. Okay, now I put this on because there are 2 things I really love about this, and I hope that many of the colleagues who do models will take this on. And one of them is that they've used this study from Zambia by Mbewe and et al. Used a direct acyclic graph. And I hope that when you're all examining potential causal pathways and mediators that you will start drawing this. There's a very nice website that allows you to kind of draw these graphs, and I would really encourage you to use them rather than bung everything into a logistic regression model and do it that way, but actually thinking about how explanatory variables link with one another. And they did this to try and investigate the association between socioeconomic status and cognitive function. And what they've done is, if you look at the green, and don't worry about the individual factors, it shows how multifactorial neurocognitive disease is. And how do you define socioeconomic factors? So they came up with an index for socioeconomic disease, for socioeconomic factors, looking at food security, water insecurity, etc. And then they came up with illness index, so illness of both the child, their viral control, their HIV-specific illness, but general illness. And they came up with a malnutrition index and looked at also negative life events, including violence, abuse, and family members. So they've really very thoughtfully put together a potential pathway of mediation when looking at association between socioeconomic status and cognitive factors. And I like this very much because they're thinking about, they're understanding the complexities of how neurocognitive function is affected by external milieu. And what they found really interestingly, this is a study in Zambia, was that socioeconomic index was associated, a lower socioeconomic index was associated with lower cognitive function. Now that shouldn't really be, surprising. We know it's multifactorial, but it's really nice to see that that they've modeled this and showed the importance of looking at socioeconomic indicators. And what they found, if you look at the plot on the right, is that the relationship of socioeconomic index and cognitive function was much stronger in adolescents living with HIV. So HIV does remain important, but the socioeconomic index is really, really an important thing to consider when you're thinking about interventions, not just focusing on biological parameters. Oh, sorry, I just want to go back and, oops, I beg your pardon. Oh, I'm just going to kind of like come back to my last slide, that when you're looking ahead at neurocognitive disease, timely diagnosis and initiation of ART is really important. We need to be aware of the neurocognitive manifestations because they're multifaceted drivers and impacts. We need to be focusing on ART delivery, beyond ART delivery, and achieving viral suppression. And what we really need are culturally appropriate, scalable clinical tools to assess neurocognition and focusing on integrated mental health care within primary HIV care. And importantly, we need to be focusing on both educational and psychological support, but also to nutritional management and caregiver support. And our research will really need to have longitudinal studies taking account of changing epidemiology and addressing the limitations to date. So I hope that I brought to you how limited the studies are, but actually that neurocognitive disease is there. It's subtle, so we don't see it, but we need to find tools so we do see it. Otherwise, it'll remain invisible in clinical practice. Thank you.